Welcome to the Mindset Matters, the podcast where psychiatry, medicine, and real human experiences collide, all through the eyes of two psychiatric PAs.
We're your hosts, PA Mercedes Dodge and PA Jessica Spissinger, two passionate psych PAs on a mission to bridge the gap in mental health care.
So whether you're a provider just here to level up your psychiatric insight, increase your mental health skills, you're in the right place.
Each episode, we shine a light on the incredible work PAs are doing in psychiatry and beyond. Our goal is to build a community focused on better patient care, professional growth, and personal well-being.
This podcast, a little disclaimer, is for educational purposes only. We're not here offering medical advice, psychiatric advice. If you or someone you know needs support, please reach out to a licensed mental health professional. All right, guys, let's dive in.
Hello, how are you?
I can't wait to hear about MAOIs. I feel like it's an interesting topic because it's like relics from the past. Do you know anything about this in practice? And is there a spot for using MAOIs in clinical practice today? I think that's where I'm curious on what you're going to share with us.
Yeah, so we're definitely going to dive in as usual. I'm going to go into the historical development and the progress along the way. As I said last time when we went over the tricyclics, there's something to be said about respecting your elders. We take that very seriously in our lives. And I think it's the same to be said for the psychotropics in which the foundation of our profession has been built, even if they are kind of relics from a distant past. They turn into new things, which then turn into new things. And all of the medications we have today are here because of the forefathers of our medication. So kind of on that note, we're going back, we're going to dig into those crazy times of the 1950s, which is really when there was like a total emergence of psychotropic medications where there had never been any before. So here's some of our OGs, and we're going to go through them. We've already talked about the imipramine, the tricyclic, and we'll probably talk about some of the others, like the original benzodiazepines, diapoxide, chlorpromazine, of course, thorazine, lithium, and the metpromate was actually a tranquilizer. And then, of course, today we're going to be doing ironazide. So what do you know about MAOI?
Not much because I don't use them. I mean, I know about how there's a lot of drug-drug interactions, and that's been kind of ingrained when I was learning medication and pharmacology. So don't use it when there are other drugs involved, and something about thyroid. So maybe I'm just remembering what I need to know to take some tests.
Absolutely. And I mean, oftentimes that's kind of how it is with MAOIs. You need to know them so that you recognize them on a patient's chart and you don't put something in there because we've just so rarely prescribed them. So we're going to go through a couple myths. Here are some myths that we want to question. One is that they require strict lifelong dietary restrictions. Truth or myth? What do you think?
I think the tyramine is truth. So I think yes.
MAOIs are outdated and no longer used.
Yes.
All MAOIs work the same. MAOIs are too dangerous to prescribe.
For my comfort level, yeah.
Which is fair. Okay, so we're going to investigate some of those myths. Just like you said, very rarely used. The biggest risk, how they can increase sometimes the wrong monoamine concentrations. There's some right ones, but then there's some wrong ones. The wrong ones mainly come from food interactions. When I talk about medications, I'm always like, where did it start? How was it developed? Where do you think MAOIs came from? How were they discovered?
Well, I think a lot of the history comes to we found this thing used for something else. Maybe we should use it for this. It's always that kind of
Very
story,
true.
like accident discovery.
Yes. And so, sometimes like medications come from plants, like Depakote is actually from the Verilion plant, which is kind of cool. Lithium obviously is an element. So it's always interesting to say, where did this drug actually begin? And in the case of MAOIs, it's like literal rocket fuel. It came from hydrazine compounds. Hydrazine is essentially a colorless, highly hazardous liquid, has an ammonia-like odor, in case you ever want to smell it, but you shouldn't. And it was discovered by this like father of organic chemistry, Emil Fischer, in 1874. But then it kind of like was forgotten for many years and it came back into the picture around World War II. The Germans started to do a lot of research on how it could be developed as a fuel, and they turned it into this stuff called sea-stoff, which was a combination of hydrazine with methanol and water. It would ignite on contact when you mixed it with hydrogen peroxide. They used that to fuel this German plane, Messerschmitt fighter plane. But they were enthusiastic about doing all this research. And then the war ended, and there was all this extra surplus of hydrazine. And they're like, oh, gee, what should we do with it? And they're like, hey, I have an idea. Let's send it to some pharmaceutical companies. And this always blows my mind. It's like the kind of tinkering that was going on with medications back then. Sure, let's see what happens if we
Why
mess around
not?
with a particle of fuel and then give it to a person and see how they react. The reason why it came to be is that there had been some like inklings that from people who were researching the hydrazine that it had antitubular properties. This was very much the era of tuberculosis. And so looking for something that would actually help make some headway with TB, because, think back, this day and age, we have such great vaccinations. We don't really have to worry about it. But these were like the days of consumption. So these two researchers, Herbert Hyman Fox and Harry Yale, between these two different pharmaceutical labs that started to get involved with this like groundbreaking research. So think back to these days of like people going to the sanatoriums, the like Victorian swoon who's dying of consumption. They were just like, how do we help these people? And with these hydrazine derivatives, they actually started to make some progress with this chemical called iproniazide. They're making headway on iproniazid versus isoiazid, which had been working for TB. Turned out the iproniazid doesn't work as well for TB, but it actually had such a strong effect on the central nervous system that even though they were looking for improvements with the pulmonary, effects of the tuberculosis, they started to see some other effects, greater vitality, motivation, social activity. So this is all Seaview hospitals over in the New Jersey area. But meanwhile, over in Northwestern, there was this team at the Northwestern Medical School that was looking at the iproniazide and realizing it was capable of inhibiting monoamine oxidase. They were just starting to understand what is a monoamine oxidase, what is a neurotransmitter and substrate. And they were looking at all these studies and noticing that the serotonin in the brain was being metabolized or essentially kind of gobbled up by the MAOIs. That was their main role. And this was actually thought for a long time to be the only way in which serotonin was destroyed. They didn't know about reuptake inhibition. They were just like, it's the MAOs gobbling up the serotonin. And then circle back to CBU Hospital, what they were noticing is that, I just showed you that picture of that TB ward. People were so enthusiastic. There was this like photo that was released, which I tried to find. I couldn't find it anywhere, but it was from Associated Press, released in 1953 of CBU Hospital, where the TB ward, people just partying. They had been taking isoproniazide and they were like, yes, they were ramped up. They were dancing. This quote from the caption was like, the only sound here was the sound of victims of tuberculosis coughing up their lives. And then this other quote was like, this is kind of funny. Dancing in the halls, though. At first I had to look at that. I'm like, wait a minute, that's how we talk now. But it's, though there were holes in their lungs. So wild, right? It's just, but also like it made so much sense. But these people were using it just looking for the TB effect. But there were some astute clinicians who were noticing and paying attention that actually maybe this could be helpful for people who are having a hard time. So now we enter in Nathan Klein. And he was the first one who really was like, I'm going to take the bull by the horns. I'm going to do a study on this medication to see what the psychiatric effects are. His study involved 17 highly kind of like inhibited, meaning very impaired patients who were dealing with severe schizophrenia, depression. They were all patients at his private surgery, which was what private practice was called. Essentially, they were giving the iproniazide 3 times a day. And what he found is like 70% of the patients who received this had improvement with their mood, with gaining weight when they had lost their appetite, with interpersonal capacity. And I mean, you think about a medication today that would have a 70% improvement, wild, right? But you have to remember, this is the age of sanatoriums and asylums. His population really didn't have any other options of treatment at the time. So it makes sense that everybody did have some sort of response. Fast forward a year, and now iproniazide had noted this does have some psychiatric effects, but it still didn't have any FDA approval for use. A study was done as an off-label use. Within 1 year from that study of like 17 people, over 400,000 people were treated with this because there was just no other big games in the town. Like imipramine was kind of coming into development, but the MAOIs were truly like the first recognized antidepressant. And then, of course, we have the typical pharmaceutical domino effect. So we're like, wow, we found something that works. We're going to make more. We're going to try to make it better.
These medications have very hard names, and I can now understand why when pharmaceutical companies are developing medications, they do a brand name that just flows off your tongue because these
Yes.
names seem so hard to pronounce. I'll give it a try.
You want to give it a try?
Yeah, I was going to give it a try. Isocarboxysted, cypramine, phenylzine, and then other hydrazine derivatives like nilamide and mebenazine and phenoprazine, or then indole derivatives, eteropectamine. Yeah, those are a mouthful. Yeah.
Yeah.
And easy to forget.
Yeah, absolutely. Especially when there's something that like you're not using day to day. As you can see, there's lots of different players that came to the arena. The tranylcypramine and the phenylazine, and I'm not even going to try to pronounce the rest. You did a good job
Yeah.
with what you did.
They were so hard.
So, as they kind of continued this research, they actually did discover that in addition to the MAO, like the MAO wasn't just this solid format compound. There was actually nuances within it. And there's two other functional forms that were noted. The MAOIA was essentially like another aspect that was located in intestinal lining, and it was associated more with the depressive symptoms. The adrenaline and noradrenaline and serotonin are more affected by that functional form versus the MAO, which is more metabolizing the benzylamine and the phenylethylamine, which is essentially going to result with that substrate of the tyramine. So the classic MAOIs, like all the ones we just spoke about, were essentially broad stroke MAOIs. They irreversibly inhibit both of those two functional isoenzymes, even though it was noted that it was really the MAOA that we want to target as the antidepressant. They just couldn't make any headway with that. So to conceptualize how the MAOs, the monoamine oxidases work, you've got your norepinephrine and serotonin kind of bopping around, and they hit that cellular receptor pathway. It's on the mitochondria area of the cells. And the MAR is, okay, I'm going to take your norepinephrine, I'm going to break you apart, and I'm going to take your serotonin and break you apart because we don't need to use you anymore. So this is MAOs are like the cleaning crew. But what happens when you do a monoamine oxidase inhibitor is you shut down that mechanism, and then we're flooded with norepinephrine and serotonin. But here's where the problem lies. When you're unable to be selective, you're getting all this excess. And we're going to go into tyramine later, but that's where that food concern comes from and some of the less favorable side effects.
That makes sense.
So now here's when I'm going to switch to the old brand names, even though we don't use them anymore because they're much easier. There's been a whole lot that have come and gone. The first one was like the OG, right? We talked about this, the iproniazide. It was branded as Marsalid. That actually went out of favor. I'll talk about why. And so the main four that are on the market is Marplan, Nardel, Parnate, MSAM. And these are the ones that we most often recognize, not commonly, but we know them enough that we know them when we see them. And here we started off with a story of how the MAOIs came from hydrazine derivatives in surplus. But there was a lot of research going on at the same time. These two other agents, both Parnate and MSAM, have a different derivative. They did not come from a fuel surplus, which is really interesting. In fact, they both came from stimulants. I always think of tricyclics and MAOIs being the first antidepressant, but that's not true. The first antidepressant ever given for depression was amphetamine in 1939. So they were around that they could be tinkered with. And that is where the Parnate and the MSAM come from. One is the amphetamine analog, the other is the L-methylphenidate derivative. Iproniazide is like out of favor. This is the retired original MAOI. It was originally tried for tuberculosis. It was found to not be helpful at all for tuberculosis, but fortunately it was determined that it had the mood effects. So it was officially FDA approved for antidepressant, antidepressant uses in 1958, but it wound up being withdrawn by the early 1960s due to such high rates of hepatic toxicity. So while it didn't live very long, it definitely laid the groundwork for the others that would follow. The first being what I call the bro, Marplan. And this one is still in existence now. It's again derived from a hydrazine, but it was a synthetic form. It's essentially irreversible, non-selective, shutting down the MAO. It had approval by the 1960s and it survived for a long time. Even though it still is a problematic medication and hepatotoxicity is a concern, it hasn't been as bad. Phenylazine or Nardil is sometimes called the workhorse. Have you heard of this one before?
Well, I recognize Nardil, but I never considered it a workhorse. I'm interested in
No.
why it got that name.
Yeah, it's interesting for sure. So this is again a hydrazine derivative. It's irreversible, shuts down the whole MAO. And this came to fruition in the 50s. It was approved in 1961. The reason why it's considered the workhorse is because it covers a lot of bases. It is clinically indicated for major depressive disorder, usually treatment resistant or atypical, but it's also very helpful for panic disorders. And that's because it touches upon some of the GABA, like transaminase. And so we get that like GABA calming effect. Compared to some of the other MAOIs, it has a higher synaptic level of serotonin, norepinephrine, and dopamine. And then it's got gabapentin. So it's like pulling in all the big guns. And that's why it's sometimes called the workhorse. Not my name for it. The OG names were mine. This was a very stout, well-used medication. I still have seen it from time and time again. Very
Yeah.
rarely, but I still have seen it a few times.
I'm
And
just
I actually
curious.
had to prescribe it to somebody who was already on it, and I continued it.
I might have had the same case. Someone that came in with that Nardil.
So with Parnate, this is one of the medications that has the amphetamine analog. It was being synthesized and experimented on in the late 40s, early 50s. They were thinking that maybe it would be helpful for an antihypertensive potential. However, they wound up finding out in 1959 that it also had the same properties to irreversibly inhibit the monoamine oxidase. They developed it and then was ready to go out for FDA approval by early 1960s. What was interesting with Parnate is that because it didn't come from the hydrazine, there was a lot of hope that this would be the MAOI that would not have all the like problems. It wouldn't have the hepatic toxicity. It wouldn't have the hypertensive cautious. However, because it is still that irreversible, non-selective MAOI inhibitor, it unfortunately does. But it was still somewhat tolerated a bit better and remained in the market by about the 1980s before the next wave of antidepressants came out. It was about 90% of all the MAOIs that were being sold in the US was Parnate.
Parnate. Yeah, because I do see that still
around. I think it's associated with the energizer and had the more rapid onset of mood elevating effects. Being an amphetamine analog makes sense. It's still used today, but it's very niche and definitely have to work with the patients carefully. All right, so the last one we're going to talk about is salicyline and SAM, which is called the patch because it comes in a patch. Have you heard of this one?
No, I only know the birth control patch.
There's so many patches these days. There is an amphetamine patch for ADHD, but this essentially was the first time that we had that selectivity along that MAOA versus B. Here we have a medication that's actually having some nuanced response to those different pathways. It was considered the first selective MAOB inhibitor, but what's interesting is that it works differently at different doses. So essentially at the lower doses, it's irreversible selective MAOB inhibitor, which essentially just slightly increases dopamine and it lets the tyramine be metabolized. And if you have tyramine being metabolized, yay, we don't have to worry about dietary restrictions. However, you can ramp up the dose, but then it also will inhibit MAOA. So then you get all of that good serotonin norepinephrine kicking. Right. They found that it would be helpful with Parkinson's, and it was approved for Parkinson's as an adjunct with levodopa in 1989 because of that dopamine boost. And they were like, hey, you can actually kind of be all right with how you eat. And then this is actually one of the questions I was going to ask, but spoilers right here, as far as like, when you think of an MAOI, when is like the last time you think one was like rebranded and reused? You probably would have thought 1960s, 1970s, right? But in fact, as recently as 2006, there was a new formulation where salicyline was released as a patch. And through the patch, it actually bypasses the gut liver first pass metabolism, allowing us to have more freedom and like some breathing room with that tyramine restricted diet.
2006, wow.
Right? Not that long ago. And while I have not really worked with this specifically, I have patients that I've had to take that into account when modulating medications. Any questions about this?
No, it's just that I was just curious, even though it was 2006 that was kind of rebranded, I still don't see a wave of these medications. They have not won any popular contest.
No, unfortunately, no. But again, it's good to just know where they are. And I've learned so much from doing this deeper dive. So everything has two sides of a coin, right? So we talked about a lot of the strengths of the MAOIs, and now we're going to talk about some of the reasons why they're not used as much. Even though they're all different, the blanket side effects that's most known for is that postural hypotension, insomnia, agitation, sedation, sexual dysfunction, increased blood pressure, dry mouth, constipation, urinary hesitancy. And that's because, with all of the catecholamines that are being blocked from being metabolized, it's touching on a whole lot of different neurotransmitters. Okay, so there are some main contraindications where you never want to prescribe these meds, like absolutely never. Absolutely. If there's any pheochromocytoma, if there's congestive heart failure, hepatic disease, and diabetic patients can be done, but extreme caution. And you already don't want to do it, so you're definitely not going to. And that eliminates, especially congestive heart failure, diabetic patients, that eliminates a huge population
Well,
from treatment.
I think also hepatic disease, to be honest. I mean, I'm sure there's a
that's true.
change from the past to now in regards to fatty liver. I'm seeing a lot of elevated liver enzymes, not just from alcohol use, but there's just so much fatty liver in our population that I'm like, why would I want to risk putting a patient on an MAOI? So,
Yeah, absolutely. So we're going to talk a little bit more about the tyramine, but essentially, I like to think of MAOIs as like anti-charcuterie because all of those yummy, savory bits that you want to snack on with your wine and beer, you're not touching them. And, part of what it is these dietary amines are actually taken up in the sympathetic nerve terminals, which can cause our endogenous catecholamines to hype up. And that's where the adrenergic crisis with malignant hypertension potentially and hypertensive crisis can emerge. So what is tyramine? Do you want to take a guess? What is it?
it's one of the things in a cheese.
What kind of thing?
A naturally occurring amino acid in a cheese.
Exactly. It is a naturally occurring trace amine, which is derived from the amino acid hydrazine. It is naturally occurring in plants, animals, metabolized by multiple enzymes. So not just MA, that's just one of them. There's lots of different pathways. And again, it can act as a catecholamine releasing agent. The thing is, it doesn't cross the blood-brain barrier. So we've got all of these catecholamines being released, but they're not going to the brain. They're going to like the peripheral sympathomimetic system, which is where the hypertensive crisis occurs. So that's why it's like a peripheral vascular emergency. So here is the list. And when I did have a patient who was on, I believe it was Nardil, every time we got the prescription, the pharmacy would read me the list. He got the list. We all got talked to about the list every single time. Didn't matter if you'd been on it for 4 years. It was just very highly emphasized to make sure that you never forget. I often say I was kind of calling it the anti-charcuterie, but it's like a lot of the good stuff in life is off the table for a while. So having somebody, we talk about medication compliance, like dietary compliance is way harder than medication compliance. You've got to know your patient. They've got to understand. They've got to have that health literacy to really respect that they are not going close to any of these. And like we're talking about beans, vegetables, fruit. It's not like fresh vegetables, but it's more if they're fermented or pickled, but sometimes even overripe fruits. I also read that the tyramine levels actually go up in a lot of foods when they're at room temperature for longer period of times or they're going past their freshness date.
That's so interesting. I think that we're going to have to do a deeper dive on food and nutrition because there's some evidence about fermented types of foods or fermented vegetables, how it's good for your gut.
The probiotic effect, but not now. All right. So drug interactions, that was one of the first things you mentioned. It's very problematic. They're hepatically metabolized with the CYP450 system. There's that serotonin syndrome risk. And that's a huge question that like board exams love to imp you on. Somebody's always on an MAOI. Then they start at SSRI and then they get serotonin syndrome. Very classic. So you have to have that 2-week washout period. If you're on an SSRI and you want to start an MAOI, you've got to wait 2 weeks till you start it. And when you're on it, you want to stop it and start an SSRI, you've got to wait 2 weeks until after you've stopped the MAOI to introduce another serotonergic medication.
Yeah, that's a pearl. That's going to be on a test.
Here's a quick MAOI comparison table. And the nice thing with MAOIs is while they're complex, we never use them. There's only 4. So learning them isn't too hard once you get used to the tongue twister nature of their names. So a couple of just like resources for review. I like to think of like kind of breaking them apart for their primary indications because there is that nuanced element of the salicyline, especially being for Parkinson's,
Mhm.
the Nardil, having that extra effect on panic disorder. And then the other two essentially just being straight up treatment resistant depression. So I think, kind of going back to our myths, let's take another look at them
I
and see
think
if we
I
have
got the
different
answers right.
answers.
Maybe not.
Let's see.
What
Let's
was the
see.
myth?
Okay.
Let's see. Oh, okay.
So all MAOIs require strict lifelong dietary restrictions. You said yes. You
I
change
said
your
yeah.
answer
Well, I mean,
because
I didn't know about salicylium, but when you do higher doses, though, is it true that like you would then it would be impacted?
so at the higher doses, it's the MAOA inhibition happens, but that actually is not problematic for the tyramine. That just means that you get the antidepressant properties at that dose. But with the selective low dose, you just get the dopamine effect because it's
Well, that's
selective MAOB, and MAOB is the main one.
it's
So
the
it's
one with the.
selective, so the
Mhm.
tyramine gets metabolized. However,
But
it doesn't mean it's free and clear. The same dietary restrictions,
are still recommended
warnings are still like,
FDA. So I was kind of right, to be honest.
yeah, but nuanced. And now you know that too. MAOIs are outdated and no longer used. I think
I
you
think
said
they're still.
no.
I think they're still outdated.
That's almost two things. Yes, they're outdated, except the rebranded in 2006. That's also outdated.
No, that isn't.
And you definitely wouldn't say that they're no longer used. We've both seen them pop up.
We have. Yeah.
All MAOIs work the same way. You said no. Got
Mhm.
that. And MAOIs are too dangerous to describe. Well, I think that's still like in the eye
I
of the
think it's like
beholder.
I that's gonna say it's clinical preference. But yeah,
All right.
this is a great
So,
big insight on the history of MAOIs and just learning more about it and refining our knowledge about it. So it gives us an understanding that, yeah, it's a relic from the past, but also it's good to know where the story started and who are the players to explain why there's a lot of dives into pharmacology and changing the neuroreceptors and what we're trying to help with depression or anxiety. This is great. Thank you so much. This sounds fun. Hopefully, the listeners found this mini mindset exciting and new. Drop in what other medication or mini mindset topic you'd like to listen to, and we'll jump into that too. Thanks for joining us.
bye.